Hello everyone, this is Dr.Lijesh Kumar, Head of Department and Senior Consultant, Department of Endovascular and Endocrinology, Lisi Hospital. Today we are going to speak about diabetic foot. Diabetic foot, we know we have many of our loved ones who develop ulcers in legs who are diabetic patients. And we know that the incidence of diabetes is increasing, and so is the incidence of diabetic foot. And diabetic foot, we know it plays a huge burden on the patient's health, patient's life, as well as finances of the family. And if not treated on time, it can lead to loss of limb, that is amputation, and in some cases even loss of life. Angioplasty is a technique in which blocked arteries. Arteries, we know that arteries are vessels, blood vessels that carry pure blood. And in angioplasty, the blocks in these arteries are opened up using wires, catheters, and balloons without the need of any surgery. In angioplasty, as we said, you open up the arteries using special wires, catheters, and wire combinations and balloon combinations without the need of surgery, with only a pinhole in the groin or in the foot or in hand or in the opposite groin. It's a very simple procedure, doesn't require anesthesia. And in angioplasty, what you do is you cross the lesion of the wire first with a catheter combination, with the support of a catheter. And then you place special balloons, and when the balloon is inflated, the material that is causing the block in the arteries is compressed to the sides, opening up the lumen, center lumen, for the blood to flow again. In stenting, what happens is sometimes the material that is causing the block in the arteries is elastic. That is, you open the arteries, but the material keeps on coming back to the lumen. In that case, you place a mesh around the walls of the artery so that the material does not come back into the lumen. That is known as a stent, in simple terms. And these stents or these mesh are placed using special catheters and known as stent catheters. And in some cases, the walls of the arteries themselves are not good enough to keep the arteries open. In those cases also, you place these stents to keep them open. When a person starts developing pain at rest, that is without walking, if the person has pain in the legs, or the person has an ulcer that is not healing normally, it becomes an emergency. It's known as critical limb ischemia. And if the arteries are not opened up on time and the person doesn't require proper wound management and the diabetes management, the person can lose a leg and also in some cases life. So it becomes an emergency. The other indication of opening the arteries, that is angioplasty, is when the person develops claudication pain. In claudication pain, the person starts developing pain even after walking for some distance. He or she is not able to walk properly and do the normal walk that is required for daily life. In such cases, it's not an emergency. We try using medical management in the first instance. And if the patient is not responding to medical management and the patient is having lifestyle-limiting claudication, definitely the person is candidate for angioplasty. It's an interesting story, actually. There was a great scientist. He was an interventional radiologist, very famous interventional radiologist, who is considered as a father of interventional radiology. So he had an idea long back in which he conceptualized that he can open up the blocked arteries using nothing but catheters and something known as dilators at that time. So it was a very primitive type of angioplasty, but he did not receive much support from other fellow doctors and vascular surgeons. And in 1964, January 16 to be precise, there was a lady who was diabetic, who had a blocked artery, and she was advised amputation by the vascular surgeons because the blood flow to the leg was very bad and she was not a candidate for surgery. So Dr. Charles Daughter stepped in and the patient also gave consent for the procedure. And with just a simple dilator, he took the dilator inside the artery, opened the artery and came out, and the patient did not even require anesthesia for that. And he not only saved the leg of the lady, but also the life of the lady and the independence of the lady. And thus was born the field of angioplasty and interventional radiology. Interventional radiologist is a super specialist who has a background training in radiology. Radiology, we all know, is a science in which, is a science or modern branch of modern medicine in which you use imaging techniques like ultrasound, fluoroscopy, digital subtraction angiography, computed tomography, or magnetic resonance imaging, that is MRI, to look inside the body to diagnose the diseases. And interventional radiologist goes further and uses these techniques to not only visualize the disease process, but also reach the disease process accurately, precisely, and with great care, not to damage other parts of the body, and treats the disease process. So, a technique of interventional radiology is highly precise, highly accurate, and requires very less anesthesia, or in many cases no anesthesia. So patients who are generally not candidates for surgery, they are still candidates for interventional radiology techniques. And because the wound is very small, or in many cases not visible at all, the recovery is very fast, the hospital stay is very less, and in many cases, because of all the advantages, the cost of the procedure or the cost of the entire treatment is very less compared to open surgery. So as we said, angioplasty, or the birth of interventional radiology, started with a lady who was not a candidate for surgery. And diabetic patients, we know, they have many diseases. Many of them are heart patients, many of them have kidney issues, all these things. And many of them are not candidates for surgery at all. So traditionally, these patients went for amputation, that is, loose legs. We had to cut their legs, they had to lose their legs either above the knee or below the knee in many other cases. And we know that a person who undergoes amputation, especially above knee amputation, has 70% mortality risk of dying in the next 5 years. So angioplasty has changed that scenario completely. Even patients who are very high-risk surgical candidates, they can still be taken for angioplasty, and more than 90-95% of the cases we can still save their legs. Angioplasty, if you ask me, is one of the most exciting fields or innovative fields right now, because we know that the incidence of angioplasty means diabetes is increasing in the world, and so is the incidence of diabetic foot. Our population is getting older, and that itself places all these patients at risk for atherosclerosis and blocking the arteries. So angioplasty is very different to what Dr. Charles Daughter did back in 1964. Now we have different types of balloons are there. Now balloons are coming in which they are coated with medicines that prevent early clotting. Now we have stents that are coated with these drugs that prevent clotting. And if you are, the latest advancement in angioplasty is in the field of vessel preparation devices. Vessel preparation devices are needed when the block in the arteries, as we already said, materials that are causing the block may be very tough. They don't yield with balloons, they don't yield with stents. In those scenarios, even if you do angioplasty or stenting, the results are not good. In vessel preparation devices, using atherectomy or lithotripsy, what you do is you take your devices, break those hard calcium or hard blocks, drill them into small pieces so that there is much more better opening of the arteries, and after that you do angioplasty. So the latest advancements in angioplasty is in the field of vessel preparation devices, and these are making vessels that are previously not suitable for angioplasty suitable candidates for angioplasty and minimally invasive treatments. Calcium, if you ask the interventional radiologists who are doing angioplasties regularly, is the biggest enemy of angioplasty, because these hard calciums prevent the balloons from expanding normally. And even if the balloon expands, the calcium again comes back. The calcium plaques again come back and close arteries. So the result of angioplasty is not good. And the stents also don't expand at the level of these calcified plaques. So traditionally, all these patients had to be taken for surgery, or if they were not surgical candidates, they were candidates for amputation. But now with these vessel preparation devices, there is atherectomy and intravascular lithotripsy, the calcium can be broken down, and angioplasty results are again better in these cases using these advanced techniques. Angioplasty is an essential armamentarium in the treatment of diabetic foot, and along with podiatric surgeons, general surgeons, endocrinologists, physical medicine rehabilitation experts, we make a difference in diabetic foot management now. And take-home message for the patients is that if you're a diabetic patient, if you are a smoker, if you are elderly, and you develop an ulcer in the leg that is not healing normally, or if the edges of the ulcer are becoming black, consult your doctor immediately. Get a clinical examination done, get a Doppler done, see if the vascularity is good. If the vascularity is good, that is, the blood flow is good, more often than not, the ulcer will heal with wound management and with medicines. But if the blood supply is very bad, don't think twice before getting an angioplasty done. Thank you so much.